Promising. All right. So recap, we're going over cases from October and November. And the first one we're actually starting off was a case that I got at one of my recent clinical shifts. So the chief complaint is cardioverted by EMS. And this is a Jewish hospital, and it was for a 47-year-old male. This is not a Westchester case, so I thought this was worth going over. So it should not be familiar to anyone. Gentleman has a history of AFib, CHF, and Crohn's disease, which I just spelled, who was bradycardic in the field, and then all of a sudden went from bradycardic into VTAC and got shocked twice. First time was synchronized cardioverted at 30 joules and then at 50 joules. And the report to our charge nurses is that the patient is now stable. So he came in. And I, having spent time with you guys, was smart enough to go out and say, I would like your code summary, please, so I can take a look at what actually happened. So these are the strips of what they saw when the patient was in VTAC. I think this was the first one where he got shocked at 30, and then this is the second one where he got shocked at 50 joules. And after those, patient went back into that bradycardic rhythm. And this was the 12 lead that they got. Good luck, guys. This is the 12 lead that they got right after the cardioversion for the patient. So when he got roomed in room 7, which is one of the small rooms right in front of the doc box, patient on the monitor had tons of ectopy, going in between like bigeminy and trigeminy, with a very wide, complex pattern to his ectopy. And he was a little bit altered. He was probably GCS 14, not really with it that much, and a bigger dude as well. So not someone that you really want to mess around with. And given that we were all stumbling all over each other and this gentleman looked fairly sick, we decided to move him to the trauma bay. So put him in the trauma bay, and we look up at the monitor, and this is what his heart does. And this was my face. So this gentleman, we ended up getting access on him, and while doing that, we were able to do a brief chart review. And he had a history of, due to his heart failure, being on Lasix, which is notorious for making you pee out all of your potassium. And when he had been seen about a month prior, he had a potassium of 2.5. Normal's around 4.5. Less than 3 is considered critically low. And at that time, his cardiologist decided to put him on 10 milliequivalents of potassium, which is basically like spitting into the wind in regards to replacing potassium. And he wasn't taking that every day, so basically no replacement there. On top of that, with his Crohn's, he was having persistent diarrhea for months at a time, and then started having multiple episodes of vomiting and diarrhea over the last few days, so tons of GI losses. So when we got him, we started him on MAG. He got 2 grams, like IV bolus push-in. Calcium gluconate was started by the resident I was working with, which takes about 20 minutes to go into the patient's veins, which is part of the reason we sometimes don't carry it. And that was taking a really long time. And while this was happening, he kept going into that torsades rhythm, and I ended up shocking him 3 times. To get him out of torsades. So we ended up giving him calcium chloride, and once he got that, his heart calmed down a little bit. We didn't need to shock him anymore. Put in a central line. That's what this is over here. It's a big catheter that went into his groin so that we could get him potassium fairly quickly. You can't give potassium too fast because, well, one thing, it can stop your heart if you give it too fast. And number 2, it burns like heck going through the veins. So if you put a central line in, you can get it in a lot faster. And then we ended up doing synchronized cardioversion for him 3 times. I did find this video going over doing it on the LifePak 15. And just as a reminder for everyone, if no one's had the chance to do this recently, for synchronized cardioversion, the critical things is that you need to sync up to the QRS complex. In patients who have really bad hyperkalemia, where you have T waves, you may notice that it even syncing to the T waves as well as the QRS complex. Not ideal. The main thing we want is to make sure that that shock is delivered right on the QRS complex and not on a T wave, because you can have something called R on T phenomenon and send them into a ventricular dysrhythmia. So once you sync it, you pick your charge, and then you push and hold down the shock button to deliver the charge to the patient. And as a reminder, the sync goes off after you deliver the charge with the anticipation that your patient may go into defib, so that you can quickly defibrillate them afterwards.
So the rhythm that you all the synchronous cardioversion on was an RVR, it wasn't Torsades, or what?
It was Torsades.
Oh, it was Torsades.
Yeah, it was Torsades. I think we were still able to sync it actually in that one, surprisingly. And I think I did it just to be sure, so we didn't actually end up throwing it off somewhere in there. We probably didn't need to, but I did it regardless. Let's see. And then this was his 12 lead, right after we cardioverted him, which looks like mush because it's in bigeminy. So you have this sinus beat, and then you have this PVC or preventricular complex, which is why it's a much wider QRS complex than the rest of them. The thing to note in this EKG is that with his native sinus rhythm or sinus beats, his T wave is all the way out here. It's substantially long. And you can see it in all of the different leads. So like here in V3, I think it's fairly pronounced where you see his T wave is all the way out here, about 4 boxes or so from the start of the QRS complex. So I actually gave him a QTC of 710. Normal for people is around 450 or less, depending on male or female. So the problem with this is that it can cause that R on T phenomenon just by widening drastically out your patient's native rhythm. So we ended up getting labs back on him, and this gentleman had had such severe GI losses that he had completely deranged all of his body's electrolytes. His potassium was 1.8, normal is about 4.5, and this is one that takes an incredibly long time to replace. This can take a couple days to go back to normal because of how slowly you can give it to a patient. He also had a mag that was low at 1 when he came in, so he ended up getting a ton of magnesium from us when he hit the door, as well as some calcium to try to stabilize his cardiac membranes. And on top of that, his pH, his body's carbon dioxide and bicarb were all messed up. Normal pH being 7.4. CO2, we normally expect that like we see an end tidal to be 35 to 45. His was substantially higher. And his bicarb was also very high, which is what was causing this alkalosis for him. So we call this metabolic alkalosis. And normally with this, you would expect the CO2 to try to compensate as much as it can from a respiratory standpoint by trying to hold on to some CO2 to balance it out, but it clearly wasn't able to do that enough. So it's some insufficient respiratory compensation. So I thought this was worth going over because it's an example of long QT. And it's something that we don't always pay attention to when one of the things we're looking for is STEMI or some other like clear cause of an arrhythmia. But it is actually fairly common because of some of the causes for it in the United States. In long QT syndrome, what you're looking at is the start of your QRS complex to the length of time it takes you to get to the end of the T wave. Normal for most adults is around 450 or less. I think for men it was 440, women it was 460. So I would say like 450 or less is usually the cutoff where I pay attention to it. Or if you don't want to actually count up the milliseconds, it's 2 of the large boxes or less would be considered a normal QT interval. If you're getting longer than that, then your concern is that you're going into that long QT category. And the thing we care about with this is it can cause this R on T phenomenon, where as this prolongs, at some point, you may end up having your ventricles repolarizing or going to a PVC while they have this T wave that's hitting into it. And that's what sends your heart into this arrhythmia. And usually what it'll send it off into is torsades, which is called torsade de pointe or twisting of the points. That's where you have these polymorphic VTAC complexes that are kind of getting longer and then shorter, like a bobbin that's aligning and unwinding. The main cure for this is electricity, but then also magnesium. You give them usually 2 grams of magnesium pretty quickly to try to shorten up that QTC as much as you can so that you try to prevent another RNC phenomenon from happening. So you usually end up shocking these and then giving them magnesium right afterwards. For long QT, there's kind of 3 big categories that I found that cause it. In the United States, the biggest one is probably medications, and it's because a ton of the medications that we give people cause this. Psych meds is one of the biggest ones. So people who are on like SSRIs or SNRIs, some of the antidepressant medicines, those are some of the big ones. There's a lot of antibiotics that can do it too. Azithromycin is one of the big ones that you'll see patients get all the time for pneumonia, COPD exacerbation. And then the one that affects us quite a bit is antiemetics. So Zofran, and things like Zofran, droperidol, all of the medications that we give people for nausea, Phenergan, Compazine, all of those prolong the QTC. So it's one, I think it actually has in, I want to say in the Southwest Ohio protocol, if you have time, like taking a look at the EKG just for this reason, if someone's on a bunch of other medications. This gentleman, he actually ended up starting to vomit while he was in the trauma bay and getting sick. And given how long his QTC was, the only medicine that we could give him is a benzodiazepine. He got a little bit of Ativan because any medicine that we would give him would prolong his QTC. So patients who are having a lot of these GI losses, what happens with that is it ends up messing up their electrolytes. So that'll be things like your magnesium tends to get low, your potassium, you can poop it out, you can vomit it out, and then calcium as well due to some of those GI losses. The most common ones you're going to worry about though for QTC is going to be your potassium and your magnesium. So my caution going into the gastroenteritis season that we all know and love of the winter would be if you have someone who's having that severe of GI vomiting, it's not reasonable to do a 12 lead and just take a look at what their QTC is so that you don't end up potentially prolonging it when they get some Zofran. And let's see, the last one, just for nightmare fuel would be things like congenital or structural causes. There are some people who just through their genetics, their family history, they end up having prolonged QTC syndrome. Oftentimes that's diagnosed when they're kids, but not always, depending on how much contact they've had with the medical system. And sometimes you can get it structurally. So patients who have had an infarct or death of part of their heart can cause it. Or patients who have aggressive widening of their hearts due to cardiomyopathy over time. So he ended up getting 4 grams of mag, 4 grams of calcium, and we ended up giving him 60 milliequivalents of potassium over an hour between his peripheral and his central line. And about the time the calcium gluconate wore off for him, he went right back into torsades and needed to be shocked again. So this was his EKG after all of those medications. And what you'll notice is his QTC is still really long at 644, and he's still having this bi-Gemini rhythm with this super long QTC on him. So then he got even more magnesium and more calcium and more potassium, and then got his butt admitted to the ICU. And the hard thing with these is that I didn't want to give it an anti-arrhythmic like amiodarone because some of those can prolong your QTC as well. But did want to show this to everyone because it's not something we run into very often. Actually, the medic that brought this patient in brought another patient to me later that night, and I showed him the EKG, and he said he hadn't seen that before. So I thought it was worth going over with everybody. That's what I got on that one. Questions, comments, other thoughts?
So a couple thoughts, kind of just moving backwards on the slide. So one question which I had not actually thought about before, and I don't know if it came across or if it's something on the boards that I should know about, I just forgot. But if they're, let's say if they have a QTC this long, you're worried about it, maybe like this guy's been in and out, rather than bradycardia, it's a normal high or even a tachycardic rate. Is there any role for like a beta blocker for kind of
I did not come across
decreasing the amount of QTC, QRS so that you're like reducing the chance of that in RMT?
I didn't look at, I don't know actually. That is a really good question. Yeah, I don't know.
Never, I don't really see beta blocker in the treatment algorithm for this B1.
Yeah. And the reason that you'd wonder about that is as your heart rate gets faster, your QTC actually gets longer. And then just slowing their heart rate down will fix a lot of their QTCs. So say you have a patient who's in sinus tach at 130, you may see them having a QTC that's like 502, and then they get to slow down by fluids or chilling out, or getting their pain under control, and then their QTC is like to 470, and that's much less dangerous than the 500 one. I don't know. That is a really good question.
Let me see.
Yeah.
You can actually go back, but another antiemetic that I was reminded of is just an alcohol prep pad. Have you guys ever tried that?
It works.
Yeah, and I always forget. I never have the opportunity when I have the opportunity to use it and then remember it. But if you just open up an alcohol prep pad, then I'm just gonna like smell it. Apparently, it's supposed to be like a really powerful antiemetic.
Yeah, it's usually. Yeah, it's,
I did that when I'm gonna go through all the box.
Yeah, exactly, right? Like an anti-smelling salt.
I did it pregnant at work and it works really well.
yeah,
It's not gonna prolong the QTC.
nope, they're
Yeah,
just
right.
huffing alcohol for a little bit. I know I have pictures of me doing it in the helicopter. It does work best when you're like right about to barf, at least in my own experience.
Oh, yeah.
And you literally just like open it up and have them huff it for a few seconds and then they do a lot better. So, fun fact. You can use it the next time you get motion sickness going down the road too.
Yeah, we're trying. And then go back to the pre-hospital strip in the EKG.
Yeah. EKG.
So this one, so this is the pre-hospital 12 lead.
Yep.
So the one thing that I'll make mention is that the calculated intervals are usually pretty good for this. But this got read out as 493, which is not even, I mean, it's like technically prolonged, but usually it's around 500, you get into problems.
Yep.
This guy was 700, but I think it's picking up so much artifact and other stuff. But if you actually look at your precardial leads, where you can actually see where the T wave is much more pronounced, you can see that that's like super long. And as a rule of thumb, if it's like anywhere like halfway between the QRS complexes, like as a rough estimate, that's long QTC. So even if you don't remember numbers or something, but like if you look at this, you're like, oh, those are some good QRSs, and you have a T that's like in the middle or even further out than that, you gotta be like, wait, something is up. I should probably not get Zofran. I should keep an eye out, or if they syncopize, I'm gonna be heightened suspicion for everything we just talked about. Even if the number, which is usually pretty good, is gonna lead you astray, which it does in this situation actually.
So you're saying like, say on this one here, where the cursor is, like this one to this one would be your Q to Q interval. So then like halfway would be about here or so. And it's already at least there, if not starting to go on the other side with it. So that would raise your concern for it, just looking at it. I like that. Then there's no math involved and humans error in math when the stress is high.
Yeah, it's not perfect, but if you,
No,
if you
but
see
it's
like
good
half or
estimate.
more, then it's like, all right, something is probably up.
Yep.
And then go to maybe the strip, or the one before this, I guess before this.
That's the only strip I have.
Okay.
There. Yeah, those are the strips from.
Yeah, all right. I think my last point was searching around for all the artifact for a reliable lead. And those precardial leads were, because like the limb leads are like, it's hard to even know what a T wave is over
Yes.
there, but if you look at your V2, V3, V4.
Yeah, I think
They're pretty well convinced.
yeah, the precordial ones, they turned out really nice. Like each of these can give you a convincing longer one for it. But yeah, you're right, these are full of a ton of artifact on him.
Cool. Yeah, that's good. Good case.
Something we don't see very often, but I thought was kind of a fun one.
Yeah.
I spent a lot of time in that room with the patient. Over 2 hours. Questions, other thoughts on that one? Hearing none, we will go through some of the other ones I have. So this one was a traumatic arrest that we had earlier this month. It was a GSW to the head. PED got there first and noticed that the patient was having some agonal respirations. They ended up when the first group got there, they put the patient on the Lucas device and noted that it was a single gunshot wound to the head. Yes. What's it?
Was I receiving back for this one?
I don't know.
You were, I was
Really?
That was the one. That was our case.
I didn't know that. That's funny. I just brought it up for
No, yeah,
over a
please,
minute.
yeah.
So this one, there was a big amount of work that needed to be done to get this man out of the basement, and that I don't think it's stated enough that they had to do reef stretcher and other things like that to get the patient out. Once patient got out, found that they had a pulse again, got the patient on the BBM, oral airway stuff like that, and suction the airways with an eye gel in place. One thing too I did notice is that there was TXA that was given to the patient as well, and then took the patient to Westchester Hospital, which GSW to the head that's still alive, but Westchester is pretty great. I brought this one up for two things. Number one, TXA in a head wound. I don't usually do that. I don't know about you, Dr. Richards.
Yeah, we actually debriefed about this afterward a little bit too, and I was thinking about it even after we talked a little bit. Yeah, isolated head injury, at least when we think about isolated head injury in the context of blunt trauma, we can hold off. Isolated penetrating, at the end of the day, I don't think that there was much intervention that probably would have gone one way or the other way. We did talk about that, but it is interesting because during the trauma resuscitation, trauma did end up giving QIC, but I think it was just like a kitchen sink kind of
effort with it.
Yeah. Because like in a situation like here, it's not going to be the bleeding that's really going to cause the ultimate event for the patient. It's just all the swelling and all the rest, and so it probably has limited role, at least from like a bleeding abatement perspective. So I am fairly agnostic one way or the other. I think if you're like drawing it up like on a book, on a test kind of thing, you probably hold off on it only for that reason. But again, like I said, we ended up giving it in the bay kind of as a last ditch effort kind of thing, or you could probably consider talking to your med control if you have a longer transport than what you guys did this time. And if there's some venous oozing that's causing like some issues, maybe it has some role there. But for very specific isolated trauma, head trauma, and again, we think about blunt, but it could be penetrating, it's probably reasonable to hold off. So, which is actually what you end up doing. Like we actually end up, I know you're ready to give it, but
Yeah, we did not actually.
Yeah.
Because I think that was one of the things when I was looking at the TXA protocol last month, was that isolated GSW to the head is like one of the reasons to hold off on doing TXA because of some of the concerns with it's probably not going to end up like changing the outcome with it, and if there's some coagulopathy, it may end up potentially causing some hypotension or other issues with it. It's probably one of the areas where TXA is still under research because we've been seeing a lot of stuff come out about when it's best to use it and not. But yeah, I agree. Like for those, you probably end up just calling med control for discussion on that.
I wonder if there would be a role if it was like if you really hit like the sagittal sinus or something like that, and you had like just pour, those really just pouring out venous blood from the GSW wounds. If there could be a role in that situation, that might be something where I would. That might be. Call the problem is that like there was so much going on in the back, it was hard to like phone and have that conversation.
Yeah, that's fair. So that's fair.
I think in this very specific situation, you're probably fine either way.
Yeah.
I don't think it really alters, but yeah, probably if you're sitting back and looking at black and white kind of pathways holding up is probably the right answer kind of thing, but I think just
right. And then the other thing that I wanted to talk about, because these are always the sticky wickets in regards to managing traumatic arrest. As a reminder from I think either last month or like a couple months ago, we went over traumatic arrest, and the big things that causes those is going to be bleeding, obstructive shock, or like a massive neuro insult for patients. So your priorities for management kind of go in that order. When I look at causes of things that had people die from traumatic injuries, bleeding's number one, and then obstructive shock is number two, and then massive neurologic insult tends to be in like the number two, number three spot. This patient, what I've noticed is that people like went to Lucas pretty quickly, which in the problem with GSW to the head is that it brings into question, well, what about hypoxia or that massive neurologic insult causing them to no longer breathe? So in this scenario, I think the priority of getting that airway in the patient and then trying to help deal with that hypoxia makes sense. The one thing I do caution people is that if this patient had continued to stay down, we probably should still do bilateral needles on them. Calhoun and I've talked about this a lot recently with some of these GSW to the head patients where you don't know if it's a single GSW to the head, and also a way to get practice continuing to do it for a patient that it might end up being beneficial for them later. And the problem is that what we have seen is some of the traumatic arrest cases where people are hesitant to then needle later on or forget to do so. This one where it's probably like a gunshot wound that seems more consistent with single one, I can understand why people did not do that, but that would be my one teaching point on this one, is that if this patient had stayed down, I would still say do those needle decompressions so that you get the reps in doing them. But otherwise, I do agree with, on this one, the priority of getting airway in the patient and then trying to help get their pulse back that way, presuming that this is more hypoxic from that massive neurologic insult. I was curious what your thoughts are on that too, Richards, but.
Yeah, I'm fine either way. I think the mechanism in this case was pretty straightforward, and I know that we had, at least I got a good look at the anterior of the chest. I know we actually never got to the point where we were able to look in the back, so I don't know if you guys know that, but for the reasons you mentioned, like, do they hit the ground really hard and these sort of things, like I think we have a pretty good sense of like why he arrested. I'm not object to you putting a needle in. I actually don't think it's like requisite in this situation when it's this clear cut, but I'm certainly not opposed to trying it and seeing if anything changes. The other thing that I'll highlight here too, which I do like though, is that the crews had probably a good sense of like where this trajectory was, because he actually still had a pulse on the scene. I don't think he arrested until almost the ambulance day, actually.
Right.
Yeah.
Nice.
So everything was like in place, ready to go when when he lost the pulse, pretty much pulling in. So they were quick on the chest and ready to go and doing all this stuff together. So that's the other component too, is that like if that's when he arrested, like I wouldn't like it stopped or like do anything other than what you did. But as part of the sign, I'd say like, hey, we focused on the head as the catastrophic event here. We had a bed of the chest or these sort of. Now that said, we didn't do that either, but we didn't needle or do finger thoracostomy. I think we had a good sense of what we were dealing with. But I do like the idea of, you're not gonna make them more dead.
Nope.
So it's something to keep in the back of the mind for any traumatic arrest from a general sense. So I think it's good.
Yeah. And this one is funky because of the isolated geostudy the head that was alive, which right there, that is pretty dang great for them to be with a pulse that long. So I don't want to downplay that, but I did bring up a couple other things from other cases this month, like reasons why we still do needles, even on patients where we don't know that it's necessarily going to be beneficial. Part of this because we don't know the trajectory that the bullet took most of the time, especially hitting the torso. Because if it hits a bone and ricochets, or if it's one of the ones that mushrooms on impact, etc. But no, this one I thought especially with the discussion of trying to get the patient out of the house and everything else was well done.
Yeah, especially when you're trying to like remember our priorities for like head injuries of any kind, which is what you said, which is avoiding hypoxia, avoiding any isolated hypotension.
Yep.
That having oxygenation, especially because there's like blood in the airway too and everything. So maintaining that good ventilation and hopefully by extension oxygenation was taking the airway early with an IGL is a good I think in that situation. Yeah.
I'm a huge advocate in a traumatic arrest of slamming an IGL in quickly, because then you can move on to do the other stuff that needs to be done. Even we went over this at the EMS fellow course this last week, and that was one of the things that I talked about, is that if you put an IGL in, you can quickly then free up some hands to do other things, like your needle decompression, get access, get a Lucas in place once you've done those other things, etc. But those are my big things on that one. And then this one is actually a case from last month that I will be the first to admit is an odd case, but did want to go over just because of its oddities. So this was one where the crew got dispatched to Coles for a patient that they were concerned had a seizure. When they got there, patient was a middle-aged female, sitting upright, who was sweaty, and they were able to get her up walking and got her on the cot. And patient said that she didn't have any history of seizures and didn't have any history of cardiac problems as well. And I like that the crews went over both of those, for reasons we'll talk about in a few minutes. But she did say that she was having some chest pain earlier in the week and just kind of felt unwell. They got a 12 lead set up, and then the patient suddenly had gazos fixed to the left and started going into other seizure-like concerned patient was going into another seizure. Patient got some Versed, and then patient started to have some posturing with that gaze preference. And I do like the discussion of potential concern for something wrong centrally with her brain as well. Brain hemorrhage is a great thought. When they got the 12 lead on there, patient then went into an episode of V-tach with a pulse, got the patient on the pad, so she had those ready to go. And patient then started to wake up after she cardioverted, got some Zofran, and then patient had the same episode again where she had that gaze change and then lost her pulse. They ended up coding the patient all the way to the hospital and pre-notified of a cardiac arrest.
Like the crew's still here.
What's that? I love you guys. And then the interesting thing in here is that when they got to the ER, they still noticed that same posturing and some of that abnormal activity as well. And then patient got some more Versed, pacing, lost pulse, went into arrest, et cetera, et cetera. So the cool thing is that afterwards we were actually able to go pull the EKG that was done at the time. And when I looked at this with Lydia, I actually initially wondered about a posterior MI for the patient. I think these were the two. Here's the most clear one with a good baseline on it. And I usually don't get multiple EKGs, so I was very happy with this. One of the things that drew my attention to that were concern was this elevation in AVR, but then also these ST type segment changes in the anterior leads for the patient, as well as in the precordial anterior leads as well. Because when you flip these, if you were to flip this over, these would then turn into potential like ST segment elevations for the patient in these areas if you flip the EKG over, which you can sometimes see with a posterior MI. The problem is that posterior doesn't necessarily involve those leads, and usually end up seeing this depression in AVR with it. And then you end up having elevation, or you have these massive depressions in V2 and V3. And then when you flip the EKG paper over, that then becomes a STEMI for your patient. This is off of Life in the Fast Lane, and I thought that they do a nice job showing, like, in this, actually go back, in the picture, what they have is you can read this as lead 2, and then when they flip it over, this ends up being an upside down lead 2, and you're looking at this through the back of the EKG paper that then turns it into your elevation. Exactly, you're flipping it up 180 degrees over. And if you want to confirm it, one of the things that you can do is a posterior EKG. So you take leads 4, 5, 6, and you put them on the back, kind of going from lateral to medial on the spine. So 7, 8, 9, and you look at those and see if there's elevation in those when you put it back on the patient's chest. Make sense? Okay. Let me go back here. So that was one of the things that I wondered when I looked at the EKG. Regardless, there is some pretty gnarly, consistent kind of changes in these ST segments and in some of her AVR as well. I don't think that it would meet STEMI criteria from a pre-hospital activation standpoint, but this is definitely something that is worth showing to the docs. I know that this group did that as well for the patient. One of the things that I do like that they brought up in their medical decision-making process for this patient is the discussion, is this a seizure or is this poor brain perfusion? Or seizure or syncope, what we talk about. So seizures can cause patients to have kind of those abnormal jerking motions in their whole body, but so can fainting or arrhythmias. And part of that is because with those arrhythmias, you end up not having very good forward flow of your blood. So then you don't perfuse your brain very well. So then you get these muscle jerks that we call myoclonic jerking. And it can potentially look like a seizure, but your patient is just having these muscle spasms secondary to the brain losing its ability to coordinate movements of the rest of the body. So that is one thing to be aware of. And I did like that they also brought into mind the patient's abnormal posturing as well. because seizure, kind of these abnormal movements, and then also posturing does get concerned for a central cause as well for her. I wasn't able to find on her chart, like if they actually found a good cause for what caused this. I think she ended up passing away when she was in the ER, unfortunately. So I don't think anyone did anything wrong on this case. Like I think everyone did the right stuff. Looked like seizure, got medication.
She has no falls or.
No. So I wonder if she had some underlying channelopathy causing some of her problems, would be my guess, or something wrong with her heart myocytes that led into some of this, or something undiagnosed for her. But I did want to show that posterior EKG because that's one of the things that I actually misinterpreted it as. I did want to go over some of this differential for when you have these seizure-like motions for people.
So we're thinking she probably had more than brain problem than the seizures, right?
Potentially, not sure. Yeah.
I mean, we weren't there to see that.
Yeah.
I do wonder that though. I mean, even the documentation was kind of like,
Yeah.
you know, between all the posturing,
Yeah.
like in and out of a weird funky rhythm.
Yeah.
And like seizure like activity.
Yeah, we kept coming out of it and then going back.
Yeah. Yeah.
I mean, they could have been spot on with that potential brain hemorrhage. Right?
Absolutely, yeah. So I do want to give props to the team. Their documentation on this was really well done. Really well done.
Cause you can get such weird, really concerning, ugly looking stuff with intracerebral 12 lead. And so, but it did look, I mean, definitely looks anatomic, that 12 lead.
Yeah,
Right?
yeah.
I guess the other thing that could potentially, I mean, put everything together, I think I call out for, it says chest pain on there now, or did you say something about
Seizures up the top.
Yeah, it was a
She had
seizure.
chest pain all week.
Yeah.
Oh, that's what I thought.
Yep, chest pain all week, but seizures was the call initially.
Because you wonder about like,
It's weird too, yeah.
I guess like, could have like dissection as well. It's like dissecting down into like
Yeah,
RCA.
That's a good point
you know,
too,
heart,
actually.
And then cerebral vasculature.
Sure.
Just trying to
Yep.
put all this stuff together, you know. I wonder if they could be like an ME case on this.
I gotta double check now and see if they did an ME case under, because she was relatively young.
What's that?
Medical exam.
Autopsy.
So that for autopsy, yep. So I'll have to double check and see if they
It'd be
did.
worthwhile to like ask.
Yeah,
Oh my God.
yeah.
Agreed. It
Um,
would be in her chart.
Would it?
okay.
Do you guys have her MRN or like her data service?
I'll be able to pull it up after we get done here, Lauren, so you can find it. That's what I had on this one. It is a weird case, and I still like being able to look at the code summary and everything else. Like I was very happy with how the team did with it.
Yes, for sure.
And their documentation is great, especially being able to say like, this is what we actually saw the patient doing. That is incredibly helpful in the retrospective scope. So even if your patient does something funky for some of these neurologic things, that is actually incredibly helpful. We'll even take that into account with a person that's coming in for first time seizure. What is witnessed by EMS, we actually put a lot of stock into. So that's just one thing to keep in mind for patients. Because what you see the patient doing, we may not see that happen again in the ER. But then what you describe can sometimes help localize where that seizure focus is in the brain or some of the other areas to be worried about. So, or if we're trying to figure out if it's a seizure or if someone is having some psychogenic type seizures.
That's the 12 lead, right? Good one. Stayed on that.
That was
October 5th.
5th,
Yeah.
yes, at 13:38. Thanks, Lauren. And then the last one that I had, which is probably good because we're a little bit behind today, was a discussion of ketamine, which I was able to see. What's that?
Nobody else is.
They're all gone. No, the 74s are still there. The last one was, I saw lots of cases where people were using ketamine as a analgesia patient or agent for the patient, so ketamine for pain, which I am a very strong ketamine convert, so I'm a huge fan of seeing it, especially when we're trying to avoid opiates for patients as well. So what's that? So this patient was one who went down in a golf course and ended up with what was probably a hip fracture, where she had some deformity of her left thigh. And the main thing that I took a look at on here was that the patient got put on Capno, got an IV established, and got 9 milligrams of ketamine. That was done by IV push for pain. And my favorite description at the end is when she was asked about what pain, she said, "What pain?" And I just feel kooky, as the direct quote from the patient. But otherwise had no pain and was successfully treated and transferred to Westchester Hospital for further management. So again, bias, I love ketamine. I found personally it works excellent for pre-hospital care as well, particularly when people are fairly mentally amped up over the situation that they are in or pretty anxious. The one thing to bear in mind is it is a weight-based dose drug, and that is one of the things that you do need to keep in mind when picking your dosing for patients. The biggest problems with ketamine for patients is going to be things such as if you get it severe enough, it can cause respiratory depression, but it's not as common as, say, fentanyl or Versed for patients. I have seen laryngospasm if it is slowed. So giving that over the course of a minute does actually prevent that laryngospasm. The case that I had, we actually had a scope inside the patient's mouth looking at their vocal cords. And as soon as the ketamine got pushed by one of my co-residents, she pushed it too quick because we were trying to fix this patient's airway, and the vocal cords snapped shut and they just stayed shut until her body forced her to take a breath about 45 seconds later, and at that point she had desatted. So it is a real thing. Watching it on the scope. Ultimate pucker factor moment. So it is a real thing. So when you're giving ketamine, you do want to try to push it over a minute, just so you make sure that that doesn't happen. But then also trying to prevent some of that slamming patients into the dreaded K-hole or the ketamine high. With that one, what we'll often see for patients is they get this weird trip. They may have very disturbing images that they see. You may see them be like really euphoric, or you may actually see them get even more agitated. And it is weight-based. What we find is once you get to that like 0.4 milligrams per kilogram, between that and like that 1.5, that induction dose, that's where you see that K-hole. We will intentionally put patients in kind of that K-hole sedation state when we're sedating them, but we're usually giving bigger doses, so you're getting to like 1 per kilogram at that point. So they're pretty deep into the sedation standpoint. The part where I've seen the most trouble for people is like the 0.3 milligrams per kilogram up to about that 1 per kilogram is where you can potentially get them in the K-hole. If that happens, one of the things that you can do is give them a small dose of a benzodiazepine, and that helps kind of temper the agitation, freaking out sensation that they have. Same thing for emergence delirium. You see this a lot more in kids in particular. So when kids get ketamine and they're coming out of the ketamine high, what they can get is some really disturbing visions as they're coming out of it, and some of that anxiety. So oftentimes in kids sedation, you'll give them a tiny dose of benzos on their way out of it to bring them out of it.
But that will be with us, right?
That's in the hospital, yeah. Where you may see it the most is if the weight dosing is not perfect in your patient, or their patient is really sensitive to that they get kicked in the K-hole, then you may need just like a little bit of benzos, like 1 or 2 of Versed, just to try to help get them a little bit calmer.
Which that would be agitated?
Yeah, they'll be agitated usually at that point.
What about just kind of like?
If they're just chilling and staring at the ceiling.
But like you can tell, like.
Let them be.
Like in their eyes, you can tell they're scared shitless, but they're not doing.
If you're really worried about it, you could give a little bit most of the time, just let them be, and they will kind of like slowly metabolize their way out of it. Ketamine doesn't last that long either for people, it's about 15 minutes or so. And then the other things just to bear in mind too is your induction dose is gonna be at 1.5 milligrams per kilogram. And then there is ketamine for agitation that is more concentrated. That's gonna be 4 milligrams or 5 milligrams per kilogram, and that's given IM. That one, some of the departments in the area do have that. As far as I know, we still don't even have that at Westchester Hospital, right? The concentrated ketamine.
In the bags, we can't get it.
We can't get it. Okay.
It's that concentration still on shortage.
Everything's on shortage. The nice thing about that being able to give ketamine for like agitated delirium is like the old term for it, your patient that's super amped up, is that it has a very quick onset. A lot of people do have concern though that given that high dose, you may end up with some of that more laryngospasm and respiratory depression. So anytime you're getting closer to those higher doses, that is just something to watch out for and realize that you may need to take some control of their airway. If you do get a patient with laryngospasm, one of the things that you can't do is take your fingers and put it right behind their tragus on their ear, so underneath the earlobe. And you kind of are pushing in and up, and that actually will break laryngospasm. That was what broke the girl's laryngospasm. I did that with all members.
Jaw thrust?
You actually take your fingers, your 2 fingers, and you push them in and up. So you're not doing a jaw thrust. You're actually putting it like right underneath their tragus, right on their jawbone, and you're pushing like inward and slightly upward with it.
Pressure point.
I think that's the thought process. It's just some trust pressure point that ends up doing it. I wouldn't have believed it except having seen it on camera, I'll just be honest, because we were still pulling up sucks at that point, so. And let's see. Trying to think, that's the biggest one. The hardest part for ketamine is the dosing because it is all weight based. I will be the first to admit that I will actually calculate this out for patients. And just to make sure that I don't overdose them with it unless I plan to have to take their airway afterwards. There is in the Southwest Ohio protocol, there is kind of a cheat sheet for patients, and I can send this to people for as well if they want to print this out just for like badge buddy. I think this is dosing that you can use based on height and like their ideal body weight of what you should end up giving to them for that. I think that's all that I have.
So that one patient, she was released to Butler County coroner with the reports not in her chart, so I actually emailed Dr. Mannix, so I can.
Awesome. Thanks, Lauren. Really appreciate that. That's about what I have.
Yeah, good cases.
Other thoughts on things? Cool.
Cool.
All right. Anything for you guys online that are not out on runs?
Cool.
Bye.
All right.
Good time.
We will end it. Everyone stay safe. Have a good rest of the day. I can figure out how to end it.
I don't know, I think you quit sharing, stop sharing.
Yep. Stop share.
And then you can quit, yeah,
Stop the
And-
recording.
you can end it on the right, bottom right.
Oh, thank you.